they're involved in.
Great. Well, thank you. We're coming to a close. Thank you. So actually, Alan, I'll ask you to get up, and I'll ask if Jim Spigarelli, if you could come forward. We thought as we closed today that it would be good to get perspective of the leadership at the Center for Practical Bioethics on some of these issues. So we've asked Jim Spigarelli, who is the current chair of the board of the center, to join Barbara and John and me as we just bring things to a close. And I guess before we ask a question, and I have one question I definitely want to ask, but I wanted to give you, Jim, a chance to make any statement or comment that you have.
Well, I guess the first statement I would make is to thank all the presenters and participants today, because it has been very useful to me as chair of the center, because it really brings home the complexity of what, first of all, the providers are trying to do, and then looking at the ethical questions in the field. I wish every board member could have been here to hear these discussions, and they would get some level of appreciation of the complexity and what the center and Hastings and organizations like that are facing. And I think, you know, what small not-for-profits, I think a major problem is in this area that is so complex is how do we best utilize our resources to make an impact. I mean, a not-for-profit doesn't exist for profit, it exists to do good. So how can you do the most good with what you have? And these situations are quite complex, and I would guess that to me it kind of shows me that I think collaboration, institutional, strategic collaborations are really more and more important if you're going to have an impact. So that's kind of a takeaway that I have. I did have one other comment on the big data that Mark talked about. In others, the United States has had some benefit. In the late 60s, there was a National Human Adipose Tissue Bank established by the predecessor of CDC. It was later transferred to EPA for management when the passage of various environmental laws. And actually Midwest Research here in town managed that for EPA for a number of years. And in this human adipose tissue database, as the analytical chemistry got better and better, we were able to actually see, after Rachel Carson's Silent Spring and the ban on DDT, before that time you could see the increase of DDT in the United States population. After the passage of the law, you were able to see the decline of DDT in the United States population. As the chemistry got better, they were able to observe the increase of dioxins in the U.S. population, in the human fat, lipophilic compounds, and then we actually used that to compare exposed veterans in Vietnam to Agent Orange, which has dioxin as the major components, to the U.S. population. So we were able to use those then, but I don't know if it's still used now or what's become. Went back to CDC, and I don't know where it is. So we had some use of not nearly what Sweden has, but we've been able to make use of that in the past before. So.
Right. And I should have added that Jim's background is he's a chemist and is a retired CEO of MRIGlobal here in the region, so he knows from which he speaks.
Yeah, and even a chemist was able to get some of this, so I really appreciate it. That's why the whole board could have used this.
Okay. Barber, did you have any comments from your perspective as vice chair of the board of the center? And
well, I guess I just say that I think the center is doing wonderful work. It's been traditionally working in end-of-life areas and helping people actually deal with all the issues surrounding end-of-life, and most recently working in the pains area, which is really an important one with a lot of dichotomy. The same kinds of discussions that happen today can easily happen between and has happened in symposiums that the center has led between law enforcement people who think there's too much narcotic pain drugs
yeah.
around, and the end-of-life people and other treatment people who really think that patients need to have adequate levels of pain management. And so those issues, both end-of-life and pain, have been very important, but I think the center is really looking to also be somebody that can be a center to help bring the community together to discuss issues around research and particularly the learning health systems, which is going to be really important. And I think the Kansas City region, we were very clear with the CTSA, as you heard from Lauren and Rick, that we wanted that to be a regional effort to unite in the best way we can the research efforts of the systems in this region, because it's much more powerful than any one institution on its own. And if the center can help unite the ethics around that and help unite the discussion around all of that, I think that's one of the most important things that we can do as a center.
I think the learning healthcare system, and Richard sort of introduced that to me, is really the future. And I've learned today, I think if we had a seminar once a month on the learning healthcare system, we may in a couple of years really understand it. But you know enough from today that that's the way to go, and it's so important. And I wish the community, the board and the community really could get some understanding of that.
I want to raise an issue here. I mean, I see this center as a well-respected convener, broker, who one role in this area are bringing parties together, right? Who have to be part of the solution. So working with institutions, understanding and advocating for patients and that perspective. And I was actually, Sarah, on one of your slides, and you were summarizing one of the papers in the Hastings Center report. It was a table that had the 7, I think, moral obligations. And that last moral obligation was to the common good. And the objective of that obligation were patients. And it raised for me a question of what is the responsibility or obligation of patients to participate in these kinds of activities? How do we think about that? How do we talk about that? How do we communicate this with patients and population? It would seem to me that that's a role that the center has kind of done in the end-of-life area, that is to be an advocate for better communication, certainly, with patients. So do you want to speak to that? And actually, the bioethicists in the room, I'd love to hear from you on this as well, is how should we be thinking about the obligation of patients and / consumers, I'll throw that word in here too, to participate in the improvement of the healthcare system?
Well, I guess some people would argue that patients do have an obligation to participate because they're benefiting from all of these activities, and I guess they would, on the norms of reciprocity and also the common good, that they're benefiting from the kind of health care, and at some level they have an obligation to support that kind of those learning activities in some regard.
No matter how sick and vulnerable, they still have that obligation? I'm just trying to be... Right.
I agree with that. I think that's totally plausible, but I want to be careful about obligations to support research that we benefit from, and any obligations to support research that we benefit from in a particular way, right? So it doesn't follow that because I have an obligation to support things on the basis of a principle of reciprocity that I participate in a particular trial. It might be that I have an obligation to support it by, say, tax dollars or something else, right? So I do agree there probably is something like that, but any particular obligation, especially when that obligation is derived from, the mere fact that you happen to have some medical condition, strikes me as a little worrisome. The obligation may be more generalized and fungible.
Right. Lauren, I think, wants to get in the conversation here.
I just think that's a really interesting question to pose about the obligation of the patient, because at least I find that we're at a stage of still struggling to educate the investigator about the investigator's obligation to partner with the patients that participate in their studies, and in all sorts of subtle ways. For example, one of the things that we've done with the Pioneers Registry, in order for an investigator to post their study for recruiting, to have it on the website and be out there for the public to see, is they make a commitment. I mean, we have no stick really to enforce this, but we at least put it out there that they have a commitment to, at a minimum, at the end of the study, give the participants a summary of the findings of the study. I mean, this has been a huge complaint of patients, and why they then choose not to join another study is because they talk about the study I was in and blah, 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 and then I never heard from the investigator again. I don't know what happened, what the findings were of the study. So I think we have a lot of work to do on our end before we start arguing to patients what is their obligation. Right. And then from another side of it, in some of the work that we've been doing, it was interesting to find that among the community members that we talked with about our efforts, and especially with our attempts to be institutionally agnostic in what we do out of Frontiers, because we're so many institutions, that we heard loud and clear from them that we could not be neutral about that. I gave another talk that they wanted to know what institutions were behind this, because that helps them trust. You know, that if they see it's coming from KUMC or it's coming from Children's Mercy, they feel a trust. And I was at a community event earlier this week, and one of the questions I got, which was just to talk about the Pioneers Project, one of the questions I got was, what makes you different than, how do we know you're not Vince or Quintiles or, you know, I mean, one of the commercial CROs? They wanted to know, and I was clearly getting a sense from that audience that if they, you know, when they heard it was the universities, the, you know, the children's, St. Luke's, whatever, they felt better. And so I just put it back on us.
I didn't want to let Barber or Jim off the hook on this. I want you to comment here. But
my question would be back to you. Do you think that if we did expect more of the patient, that maybe the issues around harm would be diminished because patients would demand research on bad outcomes?
I don't know. Yeah.
Well, if I don't always know when patients when they experience a bad outcome that we would determine to be a bad outcome, that they would interpret it as a bad outcome. And I'm thinking more around, you know, things that happen in ICUs that, and for people who shouldn't be in ICUs. But I don't know when patients, if we were able to get to the point where patients could understand that this shouldn't have happened. You know, you shouldn't have gotten this iatrogenic infection. But they don't know that they shouldn't have gotten it. They just got it. If they were to demand, you know, that rather than just not going back in the hospital, I don't want to go back in the hospital and have that happen to me again. Is there a way for us to, if they were more participating in research, would that happen? I don't know. I'm just asking the question.
Yes. Yeah. Trying to get maximum voices in this conversation.
One way to get patients interested in research perhaps would be to get involved on talk radio, NPR, local KCUR, KMBZ, KCMO. Those people are always looking for interesting things to discuss and to involve their listeners in and generate some interest.
But do you think in principle that we should be talking about patients having an obligation to participate in research?
Sure, absolutely. I mean, where in our society today does anybody talk about the fact that the ordinary citizen has some obligation to contribute? All we hear about is we should receive from society. We're entitled. Where do we hear that we should give to society? And this is what you're doing in participating in research. And that's one way I see it.
And mine, I'm using research very broadly here. I'm specifically talking about things much broader than the usual kind of clinical trial research that we talk about in terms of a novel intervention versus placebo or standard care. I'm talking about, if we really are serious that we learn from all medical encounters and learning health systems, then that's going to, I think, put some minimal, but a little bit above what would normally be required of patients, I think, to participate in the system. So I just wonder how you see, Jim and Barber, if you see this as something that, if you agree, and if you think that there's a role for the center to engage the community here in this conversation.
I'm not sure that I have a good answer to this. I do think I'd like to see the community really involved in research and understanding it, but it's very complicated, as you all heard today. And we have many community people here, I think, who are not physicians or researchers. At least we started the day that way. And so they're becoming educated, but it's still a long haul to just even get educated about all this. So I think that really is the role that the center should have, and I'm not sure what's the best forum or way to do that. Sometimes it's informational papers, but more often I think it is these kinds of symposiums that are actually put at a level that's better for the general public. This one was specifically done for people working in this area, so that's a little different. But I think that really is important, that the public should understand what's at stake here and what's actually being proposed to be done.
I think it's.
Yeah, go ahead, Jim.
I think it's a very difficult job, but I think if it's to be done, I think, as Lauren mentioned, it'll be best be done by organizations like the center, because it's independent, not for profit, and I think the trust level would be established there easier. And I think it is a good role for the center, but be very difficult.
Tough sledding, yeah. Yes.
Just a comment. I think that the centers and doctors, researchers could use patients, families who have suffered from certain illnesses or and have either benefited from research improvements in care, or who have not had the answers they needed and want to encourage research. You can use those people as contact between the research, the doctors, and encouraging patients to participate in studies. Because sometimes having the ability to relate to somebody who's gone through what you're going through, or has not had the answers when they needed them, can really encourage other people to participate.
I think that's really a good point. And I just say that each of our reports from the Presidential Commission is used as its basis, the Belmont Principles, which you've heard a little bit about the Belmont report this morning. But one of them is specifically democratic deliberation. And every single one of our reports has recommended that there should be more public discussion of the issue, whichever issue it was. In this case, it was the whole genome sequencing and privacy. So I think it really is important to have that democratic deliberation, and that maybe really is the spot where the center can help.
And Richard?
Yes.
I just would point out, too, that we've done some significant work around that with the Patient-Powered Research Network.
Right.
And we have a very active group of patients but I think it highlights that one of the complex complexities of the issue is that these are very vulnerable patients because they're chronic pain patients who have not had good experience in the healthcare system, but they've been great participants.
Right. We have a... Right.
That information becomes that we've done to prevent some of what we used to see. We used to have a lot of pre-existing conditions, and those, we've improved that, but there's still a lot of fear about if I participate and they find this out, will I be eligible for my insurance? Will my rates go up? Will I?
Right.
And I think we've got to pull the third-party reimbursers into the conversation if we want to get the public willing to step forward.
Okay. Okay. Well, great discussion. I think we're coming to a close. I want to thank Jim and Barbara and you, all of the speakers, for your participation. And John's going to close us out. And remember, fill out your evaluations, and the docs fill out the blue evaluation if you want CME credit. And the boss.
Okay, just to kind of echo the sentiments of the board. First of all, I would like to acknowledge that this activity was a outcome of the democratic deliberation. Barber presented last year at our strategic plan to the board of directors and said every one of the presidential commission reports requires democratic deliberation. And so we said we were going to do something about that, which is why we had today. And I also want to tell you that in 2014, in April, we're taking this to the next step, kind of out of the realm of the professional and into the realm of the public. Our theme for the 2014 annual dinner will be Patients as Teachers. We have extended an invitation to a pretty prominent bioethicist philosopher who has an incredible story to tell about the death of her husband over the course of a 5-year period in which he actually made the decision to terminate his life-sustaining treatment. We don't have a confirmation yet from her for that, but basically trying to capture a very compelling public story to tell the public in Kansas City and then work with our partners as we proceed. So just a couple of things about what we're going to do, next steps for us with today. Obviously, we're going to archive this information. We will then segment it up and start pushing it out with the work of the staff and some of our partners. The podcasts and prep material we will also be pushing out again, but we'll actually take these different, I think we're actually going to try to carve up the presentations and then have them as discrete pieces on our publication on our website, and then we'll also be sharing them with the participants and the faculty that were with us today. And I also want to extend my deep appreciation to all of them. As I mentioned earlier, these are busy people, and we asked them all to come here, sacrificing their own time and treasure to share with us. So I want to extend our appreciation to them for taking this, and to Richard for kind of shepherding all of us through this process. It's been a great day. I think the final thing I'd like to say is that I think Barbara mentioned, or maybe Jim did, about collaboration. As you know, we're a pretty small shop, and the only way that we can do this work is through the largesse of the community. And many of those obviously were here today and supported us, not only through in-kind sources and support, but also financially. And that's absolutely critical. If we're going to do these forums, we have to have the resources to be able to pull them off. And so I want to extend again my appreciation to those that gave financially, and those the staff here at KU has been phenomenal on helping coordinate the electronic, the remote locations. That is also a response that we've had a number of the rural sites, and we didn't get a really good response this time around, and I think it had to do with the way that we actually constructed the day. We had a full day rather than being able to come in for an hour at a time. So we learned a lesson there. But we have had a number of institutions from across Kansas and Missouri, small institutions that are saying they can't afford to send their people to Kansas City for a day, and they can't afford to send their people to Kansas City for a semester. And if they do, they somehow lose those people. So many of the, these are coming from small liberal arts institutions that have nursing programs and everything else. They have begged us to make our material and our resources and our workshops more accessible to them. So this was a valiant effort in that first try, and we had some success, and we learned some things along the way, but we will be doing that again, trying to make this more available to them in real time. That's another thing they've asked is, don't just send us a podcast, just send us a video clip. We want to be participating with you. So we'll keep that promise to them and continue to work on that. But that obviously takes tremendous resources, and we certainly benefited from the generosity of the folks here at KU and Children's and St. Luke's and everywhere around the community, Frontiers and everybody. So I want to extend again my thanks to you for that. We will get back to you hopefully prior to the April 24th is actually the date of the next meeting for the Patients as Teachers. You'll all be receiving an invitation to that event that evening. That is our fundraiser. The evening presentation is that, but then we have an all-day workshop that we will have the next day. We're inviting folks from Hastings to be with us that day to kind of talk more about the objectives and what we plan to do with the creation of the ethical framework that we're going to be trying to work out with Frontiers and the other institutions, other partners in the community. We've also already had some preliminary conversations with St. Luke's and Outcomes Research Center at the Heart Institute, so we'll be trying to put some flesh on those bones as well. So I think with that, I would like to again express my appreciation to all of you and to our board for their support, and wish you all safe travels home, and again, thanks to the faculty.